Okay. Assalamu alaikum jami'an. Good evening. Assalamu alaikum jami'an. Good evening, everybody. Ramadan Kareem to all. Welcome to our Young Leader Forum, Season 2. Our theme for tonight is diabetes care in special situations. Tonight, we are delighted to announce the new name of the society after a humble work that started a decade back. The society will carry the name Emirates Diabetes and Endocrine Society, and it will carry the logo EDES instead of the old logo that was EDS. And that's because the society has expanded its activities that included both diabetes and endocrine related events. So welcome again to our Young Leader Forum Season 2, and greetings to all attendees and the presenters. So I hope tonight you have a wonderful learning platform that will have a positive impact on your career and gain a valuable knowledge with our distinguished speakers for tonight. Our Young Leader Forum is an online webinar that will that is a CME accredited webinar. It's 1.5. Following the session, you will be receiving a questionnaire. Kindly fill the questionnaire, and within 10 days, you should be receiving your credits. Our program will be live streaming on our EDES YouTube channel, and it will be available on demand on the EDES Institute. For the attendees, kindly, if you have any question, you can always post your questions in the Q&A box, and it will be addressed toward the end of the presentations. Thanks to our sponsor for tonight, Servier, and thanks for all the attendees tonight. So without any further delay, I'm going to start with the first presenter. Dr. Asma Al-Jabri will give us a talk in updates in inpatient management of hyperglycemia. Dr. Asma is a consultant endocrine working at Tawam Hospital. She has completed her clinical and research endocrine fellowship at Division of Diabetes and Endocrine at Vanderbilt University in US. She is as well a European board certified in endocrine and diabetes. She's also Associate Program Director for the Internal Medicine Residency Program at Tawam Hospital. Her field of interest in endocrine are osteoporosis, bone metabolism, obesity, and lipid metabolism disorders. So the floor is yours, Dr. Asma. Kindly share your presentation and unmute your mic.
Thank you, Dr. Badur, for the kind introduction. And Assalamu alaikum. Good evening, everyone. As Dr. Badur mentioned, that my topic today is going to be about inpatient management of hyperglycemia. I don't have any disclosure. My unique objectives for tonight is going to be identify blood glucose targets, describe initial steps in the management of hyperglycemia in inpatient, recognize high-risk patients for developing hyperglycemia, adjust insulin therapy in patients with hyperglycemia in specific circumstances, and provide recommendation for transitioning from hospital to ambulatory care. So why we're talking today about inpatient hyperglycemia management? Because diabetics are hospitalized more frequently than non-diabetics. 1 in 4 patients admitted has a known diagnosis of diabetes, and there is a significant number of admissions with hyperglycemia without history of diabetes. And there is a strong association between hyperglycemia and subsequent mortality and morbidity has been demonstrated. It was noticed that the inpatient management of hyperglycemia is suboptimal, and there are barriers for that. Some of these barriers are not prioritizing hyperglycemia management during acute clinical issues, less than optimal coordination of clinical care between the teams in the same department or between other departments, gap in clinical knowledge and expertise when to initiate insulin therapy and how to adjust insulin management during hospitalization. There is also a fear of causing hypoglycemia, leading to suboptimal management of hyperglycemia. Not reviewing blood glucose on daily basis is another cause, and persistent use of sliding scale is one of the most barrier in the management of hyperglycemia. So who is admitted to the hospital with hyperglycemia? We have the three categories of patients admitted to the hospital with hyperglycemia. Either patients with a known history of diabetes, hemoglobin A1C 6.5 or above, patients with a pre-diabetes history, or stress hyperglycemia due to prolonged history of illness, and their hemoglobin A1C would be between 5.7 to 6.4, or non-diabetic patients, those who are hemoglobin A1C less than 5.7, but blood glucose is high due to acute stress. So how we should monitor an admission? Any patients with a blood glucose 140 and above, any patient receiving glucocorticoid or enteral nutrition feeding or parenteral feedings should be monitored. And the blood glucose should be monitored for 24 to 48 hours after admission. And insulin therapy should be initiated of any of these patients' blood glucose started to be 180 and above. If the glucocorticoid dose increased during admission or feeding rate was increased, you should still continue monitoring the blood glucose beyond the 48 hours till the patient reach the target. So this is a simple scheme how to manage patients on admission. On admission, you should assess all patients for their history of diabetes and obtain blood glucose testing on those patients. If the patient doesn't have history of diabetes and the blood glucose is less than 140, you don't need to initiate fixed monitoring of their blood glucose. You just initiate point of care blood glucose monitoring based on the clinical condition. If the patient started in glucocorticoid, as I mentioned, or parenteral or enteral feeding. If the patient doesn't have history of diabetes, but the blood glucose is more than 140, at that time you should still schedule point of care blood glucose for 24 to 48 hours and order hemoglobin A1C for the patients. If the hemoglobin A1C is high, you should monitor the patients throughout the admission. For sure, if the patient is having diabetes, you will keep monitoring the blood glucose throughout the admission. So what is the targets for the patients? The main reason why we're monitoring the blood glucose during hospitalization because we need to achieve the targets. So our targets would be for any patients in critical areas, blood glucose should be less than 180. Patients in non-critical area like medical or surgical floor, we're targeting pre-meal blood glucose to be less than 140, whereas random blood glucose to be less than 180. Any patients on parenteral feeding or tube feeding, blood glucose should be between 140 to 180. More stringent glucose levels could be applied for a patient, selected patients who has a very low risk to have hypoglycemia. And the level we will target something between 110 to 140. So when we're admitting a patients with hyperglycemia, either diabetic or non-diabetic, we should take few steps. So one of the main steps that you need to DC all the non-insulin medications for many reasons. For example, you should DC metformin, sulfonylurea. Those patients might have poor oral intake, and sulfonylurea put them at a high risk of hypoglycemia. Metformin should be stopped because those patients might have a high risk to have lactic acidosis for one or another reason, like the patient is having AKI or liver, acute elevated liver enzymes, or the patient on sepsis. Then you should schedule point of care monitoring and specify how many times you need to monitor your blood glucose, Q4 or Q6 hours. Hypoglycemia order set should be very clearly documented in the system for the nursing staff, and you need also to clarify what the action should be taken if the patients notice to have hypoglycemia. Also, the order of insulin dosing, basal insulin, sliding scale, or fixed doses should be very clear in the system. So rapid acting insulin, either fixed insulin doses or, as I mentioned, the correction for NPO or the patients having poor oral intake should be clearly documented in the medical chart. If the patient doesn't have any hemoglobin A1C during the 3 months prior to presentation, you should order hemoglobin A1C on admission. Education by nursing staff to the patients regarding when to call to check the point of care, when to be given insulin prior to their meal, or whenever they're having a symptom of hypoglycemia, that should be clearly educated, given to the patients that education. One more thing that on admission, if you think that your patients need diabetic educator consultation, you should consult diabetic educator. And if you need a specialized diabetes or glucose management team to come and look at your patient, do please that as soon as you can, because all studies show that if you consult a specialized team for management of hyperglycemia, that would lead to a better glycemic control, decrease the hospital stay of the patient, and improve the patient outcome. So that's the initial steps should be taken on admission. What should be done during hospitalization? So ongoing management means that you need to check daily your blood glucose level of your patients, and you should do a daily adjustment of the insulin based on the blood glucose reading. And you also should consider planned discharge regimen for the patient. Few days before the discharge, you should put a clear discharge plan of the medication. So you should consider many factors when you're planning for the regimen, discharge regimen, like the feasibility and limit the complexity of the regimen. You should do modification for their previous regimen before admission, and you should schedule a timely follow-up for the outpatient appointment. Also, before discharge, you should make sure that your patient is seen by diabetic educator and clinical pharmacist to do reconciliation about their medication. So this is a simple also scheme to show you how you will decide about the medication of your patients. Upon discharge of the patient, hemoglobin A1C is less than 7, then you can easily start the patient on outpatient medication without either oral or insulin. If the hemoglobin A1C between 7 and 9, then you can restart the outpatient oral agent and discharge the patient on 50% of the hospital dose. If the patient hemoglobin A1C more than 9, then you can restart the outpatients and discharge the patients on 80% of the hospital dose of basal, bolus, or also you can discharge them on the full dose of their hospital dose. So this presentation meant mainly to discuss the hyperglycemia in non-critical area setting. Only I need to mention one slide about the ICU setting, that there is a conflicting evidence about how stringent we should go with the hyperglycemia management for patients admitted in ICU. Do we need to go be very intensive in our management, or we should go only with acceptable range between 140 to 180? So NICE sugar trial showed intensive glucose control, increasing the mortality in medical and surgical ICU. And the recent randomized control trial showed that no substantial differences in the composite of complication in cardiac surgery patients. So the acceptable range for ICU patients is 140 to 180, shouldn't go beyond 180. And the best insulin management is the continuous intravenous insulin infusion. So now I'm going to elaborate more about hyperglycemia management in non-ICU setting. So in non-ICU setting, trials show that there is a strong association between hyperglycemia and poor clinical outcomes like prolonged hospital stay, increased risk of infection, disability after hospital discharge, and increased mortality of those patients. I'm going to give you a short case now, and we'll ask you questions, and we'll ask you kindly to give us your answer. So this is a 48-year-old male patient with an 8-year history of diabetes, was admitted with a 3 days history of fever and cough, right lower lobe pneumonia on chest X-ray. He was previously treated with metformin and sulfonylurea. Labs on admission showed blood glucose of 264 and creatinine 1.4. Hemoglobin A1C 8.4. What is the best treatment options for glycemic control? Number 1, continue oral antidiabetic agent, split mixed insulin regimen, sliding scale insulin, or basal bolus regimen. So kindly give us your answer. So you have a few seconds, 10 seconds to answer. What is your best treatment options? What do you think? So this patient is coming to the hospital with pneumonia, type 2 diabetes, an oral antidiabetic agent, hemoglobin A1C 8.4. Okay, So most of you got it right. 46% chose basal bolus. So this is a scheme how to treat patients when you're admitting type 2 diabetic patients to the hospital with a blood glucose more than 140. So if your patient is having adequate oral intake, then basal bolus is the best regimen for the patient. You should stop all their oral antidiabetic agent. Total daily dose should be between 0.4 to 0.5 units per kg per day. 50% of that would be given as a basal and 50% as a bolus. Then you should adjust as needed. If your patient is going to be MPO, or you don't know about the oral intake, or the patient is having poor oral intake, then basal bolus is the choice. And you're going to start at a half of total daily dose, only 0.2 to 0.25 units per kg per day, plus using the sliding scale for correction if needed. And you're going to adjust the dose of basal bolus based on the after reviewing the sliding scale. So this is what I've discussed. Basal insulin is the choice. If your patient is having a diabetic on more than one agent of oral medication or an insulin, you should initiate the basal insulin either at a weight-based or home-based dose. There is a few situations that you would need to decrease the dose, home dose of insulin if the patient is having a good hemoglobin A1C control less than 7.5, or the basal insulin dose is more than 50% of the total daily dose, or the patient is really on very high total basal dose of insulin, more than 1 unit per kg per day. Basal bolus should be started also on admission, and you can start either a fixed dose of basal bolus, or you can start the patients on carb counting units, like 1 unit per 15 gram of carb or 25 carb per gram. And this is usually we're using it for a young patients who would be able to calculate their carbs daily. Plus that we're putting always a sliding scale correction in order in the system for daily adjustment of their regimen. So when the patient is admitted to the hospital, you need to make an adjustment for their blood sugar on daily basis if it's needed based on blood glucose. So you would review blood glucose on daily basis. You're going to sum total amount of insulin within the last 24 hours and divide it 50% basal, 50% bolus is divided in 3 doses. And you should monitor your patients if the patient has any episodes of hypoglycemia during admission. And also you need to investigate the causes of hypoglycemia. Is it because the patient's clinical condition is deteriorating, he started to have oral intake, or the patient's renal function started to deteriorate, he's now in severe sepsis, or there is missed insulin meal mismatch. So if the patient is having hypoglycemia, the total daily dose should be reduced by 10 to 20%, and this depends on the severity of hypoglycemia. You should also monitor your patients if the patient started to be off target on the higher level, and you should investigate why the patient has started to have hypoglycemia if he used to have a normal glycemia during admission. And mainly you need to check if he started on enteral feeding, parenteral feeding, or a glucocorticoid medication, or the patient started to have severe sepsis. So now, what we discussed so far, that mainly we're going to use basal bolus for all patients admitted with diabetic, admitted with hyperglycemia. Now I'm going to move to talk about specific circumstances when we're not only using basal bolus, we should tune the medication of the patients during hospitalization. So I'll start with, I'll give you 5 cases. We'll start with the first one. 62-year-old male with chronic knee osteoarthritis is referred for tune up of glycemic control prior to knee replacement surgery. The patient has a 6-year history of type 2 diabetes, treated with metformin 1 gram twice a day and glargine 24 units at bedtime. Labs showed that blood glucose 244 milligram per deciliter, creatinine is 1.2, and hemoglobin A1C 8.2. The question, should we delay surgery until the glucose and hemoglobin A1C levels are close to targets, or yes or no? So you have 2 seconds. So what do you think? Are you going to delay the surgery or okay to send the patient for surgery? So most of you, 61% of you chose to delay the surgery. Okay, let's talk about preoperative management of hyperglycemia. So preoperative hyperglycemia, we have two types of surgery. It's either elective surgery or patient is going for emergency surgery. So elective surgery with acceptable glycemic control, patients can go for surgery. Acceptable means that their hemoglobin A1C is less than 8.5, or they're having an acceptable range of blood glucose within a range of time before the surgery, 2 to 3 weeks before the surgery, or and if the patient doesn't have any clinical or biochemical signs of DKA and hyperosmolar non-ketotic hyperglycemia. So 5% of diabetic also would require emergency surgery over their lifetime. Here, we should put a targets for select elective surgery and emergency surgery. So if the patient is going for elective, our patient is going for elective surgery, hemoglobin A1C was less than 8.5, it was 8.2. That was one reading of 244. Patients can go for that elective surgery without a delay. If the patient is going for emergency surgery, you don't have time really to manage to control the hemoglobin A1C and to control the blood glucose before that. So the best thing is to start the patients on intravenous insulin infusion, variable rate during the surgery, and monitor them during the surgery. So usually the perioperative target for elective cases, 80 to 180 milligram per deciliter, and for emergency surgery, 110 to 180 milligram per deciliter. So medication adjustment the day of surgery, you should hold metformin on the day of surgery, hold sodium glucose inhibitors 3 to 4 days before surgery, withhold all other oral glucose lowering agents in the morning of the surgery, get half of MPH dose or 75% to 80% of the long-acting insulin, and you should monitor blood glucose every 2 to 4 hours if the patient kept MPO post-surgery, and keep the patient on sliding scale for correction. So that's for perioperative management. So now I'm moving to the third case. It's about 60 years old. Female was admitted with a 14-year history of type 2 diabetes with poor oral intake after abdominal aortic aneurysm repair. Surgery. She is to be started on nutrition support with a continuous enteral feeding with a goal of 1,300 calories per day. She is currently treated with a regular insulin, sliding scale insulin. Labs showed hemoglobin A1C of 8.2, average fasting plasma glucose 198 milligram per deciliter, and pre-meal glucose is 184. So what is the best treatment option for glycemic management? Sliding scale insulin, basal insulin alone, MPH or mixed insulin 2 to 3 times per day. Waiting for your answers. You have 10 seconds. So what do you think? This patient's post-surgery, poor oral intake, starting on continuous enteral feeding, and blood glucose is off target. What you will do? Okay, so 50-50, sliding scale insulin 38% and MPH or mixed 38%. Okay, so let's talk about management of hyperglycemia on patients on enteral feeding and parenteral. So any patient is starting on enteral feeding or parenteral feeding, you should monitor them closely because they're expected to have hyperglycemia due to high calories intake and their feedings. You should schedule point of care monitoring 4 to 6 hours for 24 to 48 hours, and with increases in infusion rate or carbs amount. You should DC monitoring if the patients without a prior history of diabetes and the blood glucose is less than 40 without insulin therapy for 24 hours to 48 hours after reaching the goal intake of the feeding. Insulin, if blood should be initiated, if blood glucose is more than 140 milligram per deciliter with or without diabetes with a persistent need for insulin correction. So the blood glucose target for such patients should be, blood glucose should be between 140 to 180. Insulin order should be specified clearly that the insulin intended to treat the hyperglycemia due to enteral feeding. If the patients, this is for patients, non-diabetic patients. If the enteral feeding is interrupted at any time, you should stop your insulin. And if insulin is given before stopping the enteral feeding for any reason, then after 1 or 2 hours the feeding was stopped, you should initiate a dextrose 5 or dextrose 10 at the same rate of the enteral feeding for the expected duration of action of that insulin to avoid risk of hypoglycemia. So we have a different regimen for a different type of feedings. For example, if your patient is in continuous enteral feeding, MPH is the best regimen, Q8 hours. And based on history of diabetes or non-diabetes, you would specify the carb ratio. So usually for patients without a history of diabetes, the carb ratio would be 1 to 25 gram, 1 unit for every 25 gram of carbs, and the carb ratio would be for diabetic patients 1 and 15 gram. And all along with that, you should use a sliding scale insulin correction every 4 hours with a sensitivity factor of 1 for every 50 above 150. If the patient is in cyclical tube feeding or enteral feeding, you should use MPH insulin at the start of the feeding, then halfway through the feeding. Meaning, if your patient started on feedings at 8 a.m. and expected till to continue till 8 p.m., then you should initiate the first dose at 8 a.m. Then the second dose should be given at 2 p.m. If the patient is starting on bolus feeding, then rapid acting insulin dosed with each bolus will do the job. If the patient will be started on parenteral feeding, then here you need to use the regular insulin in the TPN bag at a ratio of 1 to every 10 gram of carbs. Most of the TPN is starting with 200 gram of dextrose. That's around 20 units of regular insulin in each bag. So going back to our case, the answer would be starting the patient on MPH insulin for 2 to 3 times per day. And along with that, we will do the sliding scale for correction. So the fourth case is about 55-year-old female was admitted with COPD exacerbation with increasing shortness of breath, dyspnea on exertion with wheezing. Chest X-ray showed that the patient is having COPD changes. Patient has a 4 years history of type 2 diabetes on metformin, received the bronchodilator and 40 gram methylprednisolone IV. She is scheduled to receive the prednisolone 40 milligram daily for 5 days. Labs showed that hemoglobin A1C is 7.6 and blood glucose is 144. Question: what is the best treatment options for glycemic management? Sliding scale insulin, basal bolus, MPH insulin. You have 10 seconds to answer. So, female admitted with COPD, exacerbation, diabetic, started on prednisolone, expected to be continued on prednisolone for 5 days. She's having hyperglycemia. What is your option? 36% of you chose to start here on basal bolus. So there is no wrong answer, but we will go with the most common recommendation. And we'll talk now about management of steroid-induced hyperglycemia. So if your patient is in a critical care and is going to be started on steroids, so the best option to treat his hyperglycemia would be IV continuous insulin infusion. If the patient's in non-critical area and is going to be started on prednisolone or methylprednisolone once daily dose, then MPH insulin timed with the glucocorticoid dose at the time of giving the medication, along with a mealtime short-acting if needed. So usually you're going to start MPH 10 milligram with around prednisolone 40 milligram or equivalent in non-diabetic patients previously, or in patients non-diabetic, you're going to start on a higher rate, 20 units for around 40 milligram of prednisolone. If the patient is going to receive a glucocorticoid more than or equal twice daily or on a long-acting steroids, then the best regimen would be basal bolus insulin. In type 1 patients who are already on basal bolus, so you just need to titrate up the insulin doses for them. So bear in mind, whenever you're treating patients with steroid-induced hyperglycemia, you need to adjust the insulin doses based on the glucocorticoid dose. So anytime the glucocorticoid dose is tapered, you need to taper down your insulin dose. So the answer for the question is that we need to start the patient on MPH insulin, because the patient is taking only once daily steroid. So this is the case about a 66-year-old male admitted with community-acquired pneumonia. He is known to have type 2 diabetes on Lantus 20 units at bedtime, linagliptin 5 milligram daily before admission. He's having also end-stage renal disease, stage 4. During admission, noticed to have early morning hypoglycemia at around 5 a.m., blood glucose ranging between 70s to 80s. Pre-meal blood glucose between 100 to 140. Labs showing that hemoglobin A1C 7.2 and his GFR is 28. So the question here, what is the best treatment options for glycemic management? Hold Lantus, increase Lantus, decrease Lantus, start on MPH instead of Lantus. So again, you have 10 seconds to answer, and then we will go through the case and discussion. So what do you think? 66, diabetic, end-stage renal disease, stage 4, on insulin, Lantus, and okay, decrease Lantus. Yes. Okay, so 52% chose to decrease the Lantus. Okay, so if the patients with CKD started to have GFR below 45, you should decrease the insulin total daily dose to 0.25 kg per day. It was noticed that the hypoglycemia on those patients occurred mostly between 2 to 7 a.m. So the recommendation, you should check around 6 a.m. blood glucose. If the blood glucose around 6 a.m. less than 100, then you need to decrease the basal insulin by 20%. If the 6 a.m. blood glucose more than 200, then you need to increase the basal insulin by 20%. You should avoid completely using sliding scale insulin for correction at bedtime, even if the patient is having hyperglycemia, because it was noticed that the use of sliding scale correction at bedtime increased the risk to have hypoglycemia at early morning. It's also recommended that on the day of dialysis, you should decrease the basal insulin by 25% on the dialysis day. So, and during the hospitalization, you should put 2 different orders, order for dialysis day and another order for non-dialysis days. And if the patient is on rapid-acting insulin, you should also monitor the pre-meal blood glucose, and you should titrate up or down blood insulin doses by 20% based on a pre-meal blood glucose, if it is more than 200 or if it is less than 200. So that's about chronic kidney disease management. Then we're talking about the discharge recommendation for end-stage renal disease of patients with type 2 on discharge. So if your patient is having hemoglobin A1C less than 8, then you should stop sulfonylurea. If the hemoglobin A1C is less than 7, stop rapid-acting insulin. If the patient hemoglobin A1C less than 6, stop all antidiabetic therapy. If the patient hemoglobin A1C is more than 8, then antidiabetic agent is needed, DPP-4 inhibitor and pioglitazone, if you're not worried about volume expansion, with the low dose of basal insulin is the preferred regimen. So this is about CKD management with hyperglycemia. And now I'm going to the last case in my presentation. This is about 28-year-old female patient, 34-week pregnant, presented to the hospital in labor. She was seen by obstetrician and decided for emergency C-section. History of receiving betamethasone IM 2 doses 3 days back. Blood glucose was found to be 210 milligram per deciliter. So what is, you're called now by obstetrician to manage her hyperglycemia before going to OR. What is the best treatment option for glycemic management for this patient? Start on Vitamin, start on MPH, start on sliding scale insulin, or we're going to use variable rate insulin infusion IV. So I'm waiting for your answers. Okay, so for this one, I think we don't have the form. So for such patients, patients with hyperglycemia going for emergency, their blood sugar is really very high, the answer would be to use variable rate insulin infusion. So only few points about pregnancy. We're having two things we need to discuss: the steroid-induced hyperglycemia for a patient receiving betamethasone antenatal between 24 to 34 weeks, who is expected to have a preterm labor. So for those kind of patients, you need to monitor blood glucose very closely, and you should use a stringent sliding scale insulin correction for OB, meaning that you need to use a sliding scale insulin to achieve their targets. The targets for them fasting the blood glucose should be less than 95, and 1 hour postprandial should be less than 140. There is no guidelines how to treat such patients, but the recommendation always for close monitoring and use a correction if needed. And if the patient continues to have hyperglycemia beyond 72 hours, then you might consider basal insulin. So there is one of the algorithm, insulin algorithm was tested, which recommended to start insulin on the day 1 of starting betamethasone till day 5 post, 3 days post the betamethasone, but it was not generalized because it was only tried on a small sample of patients. So the last thing that labor and postpartum care, blood glucose target for patients on labor or labor should be between 80 to 110. And if the patient is having hyperglycemia, then you would use the insulin infusion with the dextrose infusion. So you're going to mix them to maintain their glycemic control. And bear in mind that the requirement of insulin will decline dramatically after labor. That's around 50% postpartum. So by this, I'm coming to the end of my presentation. Thank you for your attention, and the mic will go back to Dr. Badur.
Thank you too much, Dr. Asma. That was a very thorough review that we needed for our daily inpatient practice. I've enjoyed your talk. We have many questions posted to you, but we will be addressing them toward the end of the talk. So we will move to our second presenter, Dr. Raya Al-Mazroui. Dr. Raya Al-Mazroui is going to give us a talk about non-classical diabetes cases. Dr. Raya is a consultant endocrine working at Tawam Hospital. She has finished her fellowship training in diabetes and endocrine at Imperial College Healthcare in London and in UK. And she's a graduate of Harvard Medical School Global Clinical Scholars Research Training Program, and she's involved heavily in academic teaching for under and postgraduates. So the floor is yours, Dr. Raya. Kindly unmute your mic and share your presentation.
Assalamu alaikum wa rahmatullah. Thank you very much, Badur, and good evening, everyone. Today, my presentation will address non-classic diabetes cases. And without further ado, I will start. I'll start my presentation first with a brief history of 3 cases. And then we will go through the main part of the presentation, and we'll come at the end before we conclude back to these cases. So the first case is a 42-year-old man who reported to you in the clinic that he is very concerned about his diabetes risk with a strong family history of diabetes. And he stated clearly for you that despite all what I'm doing, my fasting blood sugar is always high. That was detected first time when he was age 36. He has a strong family history of diabetes in his mother, and 2 of his brothers are diabetic as well, diagnosed in their 30s, and they are both obese and on insulin. 2 of his sisters also are diabetic without obesity, diagnosed in their 40s, and they are on oral hypoglycemic agents. The patient himself is following a healthy lifestyle. His BMI is 23, and he has no other concerning issues. His labs show the fasting blood glucose of 6.1, and he has been stable for the last few years. And his hemoglobin A1C is 4.9 without evidence of any hemoglobinopathies. He had OGTT with a fasting blood glucose of 6.4 and 2 hours peaks of 9.2. Moving to the second case is a 35-year-old female labeled as type 1 diabetes since age 15 on MDI regimen. She doesn't recall exactly if she was diagnosed on routine testing or that time she had hyperglycemic symptoms. However, she had no previous admission for DKA, and sometimes she do stop her both insulins for 1 to 2 weeks and nothing happened and no DKA. And last time she did that 2 months back. She has a strong family history of diabetes. Both parents are first cousin and both of them diagnosed with diabetes in their 30s. She had 5 siblings, no one diagnosed with diabetes so far as she is aware. She had 3 paternal uncles who are diabetic, but she is not sure if they are on oral hypoglycemic agents or insulin. She doesn't recall anything about her neonatal periods. Her lab showed a hemoglobin A1C of 9.6, and she had negative antibodies, autoimmune antibodies. Case 3 is a 65-year-old man diagnosed with diabetes, age 32, labeled as type 1, treated with premixed insulin, no previous history of DKA. He had past medical history of CKD, diagnosed after being diabetic for 10 years without microalbuminuria. He had that time renal biopsy, showed glomerular hypertrophy, and he had a family history of diabetes in 3 of his children, diagnosed in their 20s, 2 of them in insulin and 1 of them in oral hypoglycemic agent, and 1 of his sons had fertility issue, isospermia. The patient himself is a slim with a BMI of 23. However, he had mild facial dysmorphic feature with frontal boozing, deep-seated eyes, and the breast nasal bridge. And some of his children shared similar facial features, but are subtle. He had a low cognitive ability, including 2 of his children, with anxious paranoid personality. He had stage 3 CKD, and his hemoglobin A1C was 8.4. And in reviewing his chart, he had long-standing elevation in alkaline phosphatase, which has been stable over the years with normal AST, ALT, and bilirubin. He had a CT for something else and found to have absent tail and body of the pancreas. Only present is the body of the pancreas with dilated biliary ducts, extra and intrahepatic, as well as hypertrophy of the seminal vesicles. So the question is, what is unusual in these cases? If you could pick up this, in case 1, the patient had persistently mild elevation in fasting blood glucose, and the increment rise in OGTT was less than 3 millimole. In case 2, the unusual thing is her ability to stop insulin 20 years post-diagnosis of type 1 and no DKA. And in case 3 is the subtle dysmorphic features with multi-system involvement. So now I will review with you the definition of monogenic diabetes. We'll go through some epidemiology and then why we need to identify these cases and how to identify them and approach the treatment. Then we will go back to our cases before we conclude. So monogenic diabetes is actually a collection of inherited disorder, which are non-autoimmune diabetes. And they are presenting usually at young age due to single gene defect, usually inherited in autosomal dominant or recessive fashion. And they broadly subclassified in different categories, including moody, neonatal diabetes, insulin-resistant syndromes, mitochondrial diabetes, Wolfram syndrome, or lipodystrophy. For the rest of the talk, I will just concentrate on moody. So in moody, which represent only less than 5% of all diabetic cases, there is a single gene defect leading to a defect in the pathway of insulin secretion. And therefore, there is a minimal or no defect in insulin action, provided absence of coexistence, obesity, and absence of defect in insulin receptor gene. And most of them are inherited in autosomal dominant. And you can see in this figure that insulin secretion in beta cell is stimulated through glucose, and this is called the triggering pathway, where glucokinase, which is considered as a glucose sensor, will lead to the phosphorylation, and then this will end up by more production of ATP. There will be increased ratio of ATP to ADP ratio, which leads to the inhibition of the ATP sensitive potassium channels, leading to the depolarization of the cell membrane. And this will lead to the activation of the voltage-gated calcium channels and the influx of calcium, increase intracellular calciums, and then through the rest of the pathway, this will lead to the insulin secretions from the insulin-containing granules. Now, you can see that there are almost 14 kinds or 14 reported types of MODY, and the list actually is expanding. However, the most common three types of MODY are HNF1 alpha, which constitute almost 30 to 50% of them, followed by glucokinase, which is almost 15 to 25%, and then HNF4 alpha. Also, this is followed by HNF1 beta, and you can see that the rest of MODYs are very rare or less frequent. And in fact, some genes doesn't have great evidence that they are causative for MODY. If you look to the prevalence of types of MODYs in different countries, you can see that, for example, in France and Italy, the prevalence of MODY2, which is GCK, is more prevalent than HNF1 alpha. While, for example, in Germany and UK, MODY3, which is HNF1 alpha, is more prevalent than GCK. And this is related to the way that these prevalence have been estimated and the way that the population have been studied and stratified for testing. Whether the population or the patients that have been selected are from registry with pediatric patients who have negative antibodies, or from referral, from physician referral suspecting MODY, and whether they have tested them only if they are antibody negative with plus evidence of endogenous secretion of insulin or not, and for how many genes they have been screened for. However, in general, the prevalence in all most parts of the world is less than 5%. In our part of the world, there is no data regarding the prevalence of MODY. There is some data on neonatal diabetes. However, this is something worth to look for, especially that we have a high consanguinity rate and we have a high rate of diabetes. Now, why monogenic diabetes cases needs to be identified? The reason is that this is one example of a great precision medicine application in diabetic care, where you are treating patients based on their genotype. So patients who are harboring HNF1 alpha or HNF4 alpha can be treated with a low-dose sulfonylurea, while patients with GCK doesn't need treatment except in certain conditions like coexisting obesity or coexisting type 1 diabetes or pregnancy. While HNF1 beta, usually they will need insulin because it is associated with beta cell development defect. Apart from the significant treatment implication, you can identify other family members, and it is a proven cost-effective model. How to identify these cases? This is the most challenging part of MODY. The diagnosis requires high index of suspicion, and it remains a challenge. And the reason is the heterogeneous group of monogenic disorders that comprise a large clinical spectrum and the overlap with other types of diabetes. And therefore, many of these patients either remain undiagnosed or misclassified as type 1 or type 2. And you need to know that there's no single approach that is 100% sensitive to detect every case or 100% sensitive to ensure that genetic testing is not done or performed in patients who tend not to have a monogenic diabetes. So I will go with you through this diagram, where we will incorporate several approaches together to identify or to help us identify these cases. The first thing to start with is a clinical approach. And the clinical approach basically is you take the history, physical examination, and try to predict which patient could have a MODY. And this clinical approach, one of the modalities that have been used is the traditional criteria that many of you know it, which is incidence or diagnosis of diabetes below the age of 25 without requirement of insulin, and several family members, multi-generational, who have diabetes. Though this traditional criteria is very specific, it is less sensitive. And if we apply it, we are going to miss many patients of MODY. And therefore, I could say that this is an obsolete and no more people are using it. Then we have the MODY probability calculator, and then I will give you some clinical hints. If we go to the MODY probability calculator, this was developed by a group in Exeter, UK. And if you go online, you need to put some variables in here. And this calculator was built based on patients that have been diagnosed with diabetes below the age of 35. So if your patient diagnosed age of 40, it is not going to work. This probability or this calculator with the prediction model improved the sensitivity and the specificity in identifying patients with MODY in comparison with the traditional criteria. Sensitivity improved from 72 to 91 and the specificity from 91 to 94. However, once you press here or click, then it will show you the result. And it will clearly tell you that this calculator has been developed in white European population. And therefore, it may not be applicable to any other population or ethnicity. And this have been already found and documented in UK as well, where they studied different ethnicities. And they found that, for example, patients with South Asian or ethnicity, they are the most likely to fit the criteria for referral to MODY, but the pickup rate is very low genetically using the MODY calculator. And this is because, for example, in this ethnicity group, they have a high prevalence of type 2 at younger age with a low BMI and several affected family members. And therefore, we don't need just a validation of these calculator and other ethnicity, but maybe also adjustment in terms of, for example, age at diagnosis or cutoff of BMI, or even adjustment to the prevalence of other types of diabetes in certain ethnicities or population, like, for example, prevalence of type 2 diabetes. Going now to the clinical hands. This looks busy slides. I try to make this table. You can take a picture. So in this table, you can take some hints from personal history or family history, or look for features which are atypical for type 1 or features which are atypical for type 2. So in personal history, early onset diabetes, which is one of the main criteria, history of transient neonatal hypoglycemia, long-standing stable fasting hyperglycemia, like in first case, excessive sensitivity to sulfonylurea, extrapancreatic features, like in third case, and glycosuria significant, which is observed along with either euglycemia or mild hyperglycemia. And this is suggestive of HNF1 alpha with the low renal threshold. Of course, if the family is known to have or harbor monogenic diabetes, or family history of neonatal hypoglycemia, and family history suggestive of autosomal dominant inheritance. Features which are atypical for type 1 include absence of pancreatic antibodies, autoimmune antibodies at the time, especially if measured at the time of diagnosis, though we know that around 10% they will be negative antibodies. Low insulin requirements. I have seen patients with HNF1 alpha on 5 units of insulin only. Evidence of endogenous insulin secretion out of the honeymoon period, more than 3-5 years after the diagnosis of type 1, like in our second case, and lack of ketoacidosis when insulin is omitted in a patient who have been diagnosed as type 1, like also in our second case. Features which are atypical for type 2 is onset of diabetes before the age of 45 with normal or low BMI. And maybe this is not applicable in every ethnicity, because as we said, for example, South Asian, they will have early onset type 2 diabetes with a low BMI. Lack of acanthosis nigricans, normal triglyceride level, and elevated high density lipoprotein. This study was one of the first studies to show that patients with HNF1 alpha are very sensitive to sulfonylurea in comparison to type 2 diabetes. And the primary outcome here was the fasting plasma glucose, where you can see that HNF1 alpha patients have a much reduction in their fasting glucose compared to type 2 diabetes, and even in comparison with metformin, while type 2 diabetes have no significant change between metformin or glucoside. So this table is showing you some hints toward features that are suggestive of each kind or the most common types of MODY. And HNF1 alpha, low renal threshold for glucose, so they will have marked glycosuria. They are sensitive to sulfonylurea, and they have a high cardiovascular risk. HNF4 alpha, they have history of macrosomia and neonatal hypoglycemia. Glucokinase, they will have mild persistent hyperglycemia, and in around 70% of the cases, the 2-hour OGTT increment will be less than 3. HNF1 beta, they will have, apart from the renal manifestation that many people knows, they will have other extra manifestation, other system involvement, and they may have also pancreatic hypoplasia with exocrine pancreatic dysfunction and urogenital tract abnormalities. Some of them also will have autistic features. Moving from the clinical approach, now we will move to the biomarker approach. And the goal of the biomarker approach is really to differentiate these patients from type 1 diabetes, because it's well known that type 1 is more common in young people. So from this approach, you want to differentiate these cases from type 1. And in order to be able to do that, you need to know the frequency and the persistence of autoimmunity, and also to document residual endogenous insulin secretion. And this have been studied already and documented that patients with type 1, almost 82% of them, they will have autoimmune antibodies when it is tested within 6 months of diagnosis, early in the disease course, while less than 1% of moody patients will have autoimmune diabetes. So we can use this way to differentiate or to discriminate between both. Also, the autoantibody can persist. And in this study, though it is old one, you can see that there is documentation of persistence of autoantibodies, especially in patients who are diagnosed age or older than 7, while the autoantibodies can disappear faster in patients who are diagnosed less than 7 years. Though this persistence of antibody is more likely to happen with GAD antibodies. This is another study which followed patients with type 1 for more than 10 years. And you can see that even more than 10 years after the diagnosis of type 1 diabetes, still patients up to 65.2 of them, they can have persistent at least one antibodies. Also, we need to demonstrate the evidence of endogenous insulin secretion. And in this study, they just recruited type 1 patient, and they just measure random non-fasting C-peptide. They used 2 cutoff. I will just describe for you, for example, the cutoff in panel B, where C-peptide was more than 0.2 nanomole per liter. And you can see that in patients who are diagnosed below the age of 18, this is the white bar, or above the age of 18. And in both cases, the C-peptide, after 3 to 5 years of diagnosis, you could still detect or you could measure detectable C-peptide in a third of cases who are diagnosed above the age 18, and 7% of the cases those who are diagnosed below the age of 18. However, with the increased duration of the disease, there is less likely to detect C-peptide. So there is less likely to be a residual endogenous insulin secretion. And therefore, this have been used to discriminate between type 1 and HNF1 alpha and HNF4 alpha using other measurement of C-peptide, which is urinary C-peptide creatinine ratio. And it has shown a great sensitivity and specificity to differentiate both conditions. However, in these cases, the patients have long duration of diabetes. For example, type 1 had 33.5 years, and HNF1 alpha also 23. So the longer the duration of disease, maybe this is a better tool that can predict or differentiate between both conditions. In patients with adult, this is a study which is a population-based coordinated study that conducted in UK, where patients who have been diagnosed with diabetes below the age of 30, but they are currently during the study enrollment are under the age of 50. They tested them whether they have endogenous insulin secretion measuring urinary C-peptide creatinine ratio. And if they have negative C-peptide, then they are labeled type 1. If they have still positive C-peptide, then they will test them for autoimmune antibody. And if the autoimmune antibodies are positive, then they are labeled as type 1. If they are autoimmune antibodies negative, then they will sequence them for Moody panel. This Moody panel here included 34 genes, including not only transcriptional factors, but also some lipodystrophy and even mitochondrial diabetes. And by this way, they could diagnose extra 17 cases to the already well-known 42 genetic cases. And from that, they could figure out that the prevalence of Moody in patients who are diagnosed less than 30 years or younger are almost 3.6%. And they tried to look for this biomarker pathway and compare it with the traditional Moody criteria as well as Moody calculator, whether they are gonna detect more Moody cases or not. And you can see that the negative predictive value of biomarker pathway is higher, and you may not miss any cases, but you will need to test more people in order to detect and look for these cases. They went further after the introduction of zinc transporter antibodies and after the introduction of population-specific type 1 diabetes genetic risk score. And then they went again to the patient who have negative antibodies, and they tested them for zinc transporter. And they could recognize that, or they could found that 70% turned to be positive. Among them who had genetic test, they have nil or zero monogenic diabetes. And of those who are negative, they went through a type 1 genetic risk score, and those which are suggestive of type 1, also none of them have monogenic diabetes. And by the addition of these two tools, they could diagnose more 18% probable type 1 diabetes that will not need further assessment for monogenic testing. This population-based screening also happened widely in pediatric in different populations, including US, UK, and Norway. In US, it was multicentric. They tested all pediatric patients who are diagnosed as type 1 diabetes, who have autoantibodies negative. The two antibodies that have been tested in all these studies are IA2 and GAD. And in US, they tested them for the most 3 common genes, and they could assess that the prevalence is around 1.2%. While, for example, in UK, they also took the negative antibodies pediatric diabetic patient, and they screened them for 29 identified genes, and they could predict a prevalence of 2.5. While in Norway, they could detect 6.5% of antibody negative to have Moody testing for 5 genes. But also they tested for antibody positive, and they could detect 2.4%. And this is where another dilemma can be raised with the population-based screen that I will discuss on later. Then I will not spend much time on genetic risk score, because genetic risk score is basically to detect or for type 1. And this score that incorporate HLA susceptibility loci that facilitate the discrimination of type 1 from monogenic diabetes and type 2 diabetes. And it is validated in white European population, and it is variable among different ethnic groups. So if you don't have one that is applicable to your population, then you don't use it. Molecular genetics, I will not spend time on this, but you need to work closely with your genetist, because you are going to encounter lots of variants of unknown significance. Like, for example, in Norwegian study, they had most of their genetic mutation classes, class 3 to 5. And therefore, you will need the help of your genetist to classify these variants. Also, there is some evidence that some of these genetic defects, they do have variable penetrance. And you may encounter rare variants that you are not sure if they are really causing Moody or not. Also, you need to talk with your genetist about your pre-probability of Moody. If it is a physician-based approach, a physician who is referring the patient with good clinical hints toward the diagnosis, then the pre-probability is higher than when you do a screen just randomly for population-based screen without knowing a lot about the clinical condition of the patient. Also, you need to be aware of reclassifications of mutations. Be familiar with the lab, the method they use to interpret the findings, and be familiar with the panel and the genes included. For example, extra gene panel does not just include transcriptional factors, but they include also mitochondrial, and they include lipodystrophy genes. Now, the treatment approach, we already touched based on this, and we said that HNF1 alpha and HNF4 alpha, they respond to low-dose sulfonylurea, while GCK does not require treatment except in certain conditions, and HNF1 beta do need insulin. However, the main question, if an adult patient, we diagnose them, as moody. They are adult. They have been diabetic for a long time. How I can predict the optimal glycemic control after discontinuing insulin? And in this UK study, they found that among 58 moody patients who have been diagnosed with moody, almost 2/3 have changed their treatment. GCK, all of them, they stopped all the treatment, and at a follow-up of 2 years, no one required further treatment. HNF1 alpha and HNF4 alpha, I will discuss them in the second slide, but I want to highlight something here, which is that some patients, they did not change the treatment. And sometimes not changing the treatment is patient choice. Sometimes it's very difficult for a patient who have been long time in insulin to tell them we will take you off insulin. So you need to explain to them, and you need to follow them closely, and also to respect their choices. So for the patient with HNF1 alpha and HNF4 alpha, they divided them into two groups. One group who responded well to diet and sulfonylurea alone, and at 2 years of follow-up, they were well controlled with a hemoglobin A1C less than 7.5. And they constitute almost only 1/3 of this group. So only 13 out of 36 patients. However, 2/3 of these patients, they had uncontrolled diabetes at 2 years on sulfonylurea and diet alone with a hemoglobin A1C above 7.5, or they required additional treatment to achieve a hemoglobin A1C below 7.5. And the difference between the group is that the patient who had or did not optimally respond to sulfonylurea or diet alone are the one with a longer duration of disease. They are the one with a higher BMI, and are the one who have a higher hemoglobin A1C at the genetic diagnosis. And this emphasizes the importance of early diagnosis of the disease and early initiation of sulfonylurea. So from this study, we could see that higher hemoglobin A1C and BMI at genetic diagnosis was associated with a reduced success on sulfonylurea treatment. And maybe this data suggests that sulfonylurea should be added to existing treatment rather than replacing it in a patient with HNF1 alpha or HNF4 alpha with a longer disease duration, more than 11 years, especially those with a higher hemoglobin A1C at the genetic diagnosis and a higher BMI. Now, what is next if sulfonylurea failed to control the patient glycemia? And then some people will add metformin, DDP4, or insulin, or GLP-1 agonist. And I will discuss GLP-1 agonist because it has a lot of discussions recently. So this was one of the first study that compared, it was a crossover randomized study of 6 weeks duration, where they compared the glimepiride with liraglutide. And both of them, they lowered the fasting blood glucose and postprandial glucose excursion in patients with HNF1 alpha. However, the glucose lowering effect was slightly greater with the glimepiride at the expense of a higher risk of mild hypoglycemia. There are several case reports now that are reporting will control the glycemia on only monotherapy with GLP-1, different types, in this case semaglutide, in this case dulaglutide. In this case was HNF4 alpha, and in the other case HNF1 alpha. So GLP-1 is another treatment that can be tried in such patients. What about SGLT2? SGLT2, there's no study on it on moody patient. However, in this study, they tried to give patients with HNF1 alpha, GCK moody, and type 2, one single dose of dapagliflozin. And to their surprise, they found that HNF1 alpha and GCK have much higher glycosuria compared to type 2. Though we know that the expression of SGLT2 is less in HNF1 alpha. However, the glycosuria was markedly more compared to type 2 diabetes. And we need still more study on this, whether it can be used in such patients or not. Now we will go back to our cases. So the first case, which had persistently mild elevating fasting glucose with increment rise of OGTT less than 3, is suggestive of GCK. He had a panel testing, and it found that he had heterozygous GCK mutation. However, it was variant of unknown significance, class 3. And therefore, he has no treatment so far, but we need to reclassify and understand this variant And we need our genetist in this case, where they can proceed with other types of study, whether functional or family segregation, to classify the variant of unknown significance. And as you know, GCK is characterized by mild stable fasting hyperglycemia, no treatment required except in case of type 1 or type 2 diabetes co-occurrence, or in obesity or in pregnancy. And long-term complications are extremely rare in this condition. Our second case is the lady who had been labeled with type 1, and she could stop insulin for a while without DKA. And her genetic study showed that she is harboring a homozygous mutation in HNF1 alpha, which was classified as pathogenic. So how did this change her treatment? The impact on her treatment, this is when she was only in insulin. You could see that almost 45% of her interstitial glucose was within target. She had 9% of interstitial glucose in the hypoglycemic range. With the addition of glycoside and the reduction of the insulin doses, she could achieve 79% in insulin target, and also her glucose variability was much better. Of course, I cannot see here, we cannot see the glucose variability, but you can depict it from the figure. So the variability improved, the glycemic targets improved. We tried to take care of insulin totally. However, we were not successful in that, and her glycemic control was worsened. During the COVID time, I could not see her and follow her only remotely, so she was reporting weight gain. And therefore, she stopped by her, she elected to go back to her insulin and to stop.
Kindly, you have 3 minutes
Yes.
for your presentation.
Okay. And then she had, again, worsening of her glycemic control with increased variability. And therefore, we go back again to insulin in combination with sulfonylurea. And this case reflects what we have said about the prediction of optimal control or optimal glycemic response in patients with long duration of HNF1 alpha. So HNF1 alpha represents 30 to 60% of moody cases. Usually they may deteriorate over time, but this depends on the time of diagnosis and initiation of sulfonylurea. And you could try other modality of treatment like GLP-1 agonist. We tried it in this patient, but she could not tolerate it. So these patients have similar risk of all-cause mortality and cardiovascular disease when compared to type 2 diabetes. Case 3 have a subtle dysmorphic features, multi-system involvement, and I don't have the genetic report, unfortunately, but he is diagnosed with 17q12 deletion syndrome. And this is, in fact, is HNF1 beta, which constitute only 2 to 6% of moody diagnosis. It is associated with multi-organ disease. Half of the cases in HNF1 beta are due to mutation, gene mutation, while half of the cases it is due to whole gene deletion. And this is a multi-system disease where not only the renal is involved, where many people think only renal cyst, but they could have renal cyst, they could have solitary kidney, they could have agenesis or atrophy of the pancreas, they could have genital tract abnormalities, including bicornate uterus, absence of vas deferens, and enlarged seminal vesicles like in our patient. The deletion or this syndrome is extremely rare, and it involves a part of deletion that involves 15 genes. One of these genes is HNF1 alpha. And they are characterized to have some facial dysmorphic features and intellectual learning disability with schizophrenia or autistic spectrum. And it is specific for the other gene. This is related to other gene deletion, not to the HNF1. So I conclude my presentation now that individualization of therapy based on person-specific type diabetes is the key element of precision medicine approach. Monogenic diabetes, despite they are relatively constitute small proportion of all cases of diabetes, but they can affect the patient diagnosis and management. And despite the demonstrated importance of making the correct diagnosis, almost 80% of these cases remains undiagnosed. The best is to combine clinical plus biomarkers to increase the pre-probability. And the field is evolving, and the key is to increase awareness and knowledge. Thanks for your listening, and the mic is back to you, Badur. Thank you.
Thank you, Dr. Raya, for interesting presentation as usual. So we move to our third presenter, Dr. Noura Al-Dhahri. Dr. Noura Al-Dhahri will give us a talk about overview of the genetic test and availability. Dr. Noura is an assistant professor at the Department of Pediatric and Department of Genetics and Genomic at College of Medicine at UE University. She's certified by the American Board of Pediatric for medical genetics, genomics, as well as medical biochemical genetics. She's a consultant clinical genetics and medical biochemical genetics at Tawam Hospital in Al Ain. So kindly, Dr. Noura, share your presentation and unmute your mic.
Thank you very much, Dr. Abadur, for the kind introduction, and thank you very much for the society for inviting me to give this talk. I'll make it very quick. Hopefully, I can really make this genetic testing, as they say, made easy. So it's very basic presentation geared toward everyone's in the audience. Hopefully, by the end of this talk, we'll be able to address the following objectives. So we'll talk about different genetic testing and what are some of the clinical indication for some of those, and some of the limitation for those genetic testing. And most importantly, I want to highlight some of the important components of pre-genetic test counseling. And then if the time allows, we'll talk about some of the ethical and legal and psychosocial issues that is involved when we do genetic testing. So before I go to the bulk of my presentation, I just want to give you basic information so that we are all on the same page when I start using some of the terminologies. So all of you have seen this picture when you were in high school, or if you studied biology, or back in the first few years of medical school. So you all know that our genetic makeup is made of 3 billion base pairs. This is tightly condensed in the nucleus, and those 3 billion base pairs are almost equivalent to 20 to 25,000 genes, according to the estimation after the Human Genome Project. So we can look at different way using genetic testing to this material. We either look at the level of the chromosome, or we look at the level of single nucleotides. So basically, single genes. So, and for us to understand some of, genetic alterations that occurs and might result in disease, basically some of those include chromosomal abnormalities, something we call aneuploidies like the trisomies or monosomy X. And then the copy number variation, when we have a microdeletion or a microduplication, that will be a piece of a chromosome missing or extra. And within that region, there lies, several genes. You can recall the example that was given from Dr. Araya, the 17q12 microdeletion syndrome she was referring to. Or we can have alteration at this level of the genes. So single gene mutations, those involve like few letters or one single nucleotide change, or duplicated or missing. And then we also have some other genetic alteration that can occur, which is not applicable here for the audience with endocrinology background. So trinucleotide repeats or epigenetic machinery. Okay, so when we do genetic testing, we always think, is it like a diagnostic to rule out a certain condition or confirm a certain diagnosis, or is it a pre-symptomatic or predictive testing, or like a carrier testing for at-risk individuals within the family? Or is this like a prenatal testing, predictive or versus diagnostic? Or this is testing as a prevention, like in the cases of pre-implantation genetic diagnosis? Or is it a population-based screening? Or is this like newborn screening, which is in most of the cases, this is biochemical testing. So some of the benefits that we gain when we do genetic testing is obviously providing explanation for our patient symptoms, and then allowing informed decision about making, proper decision about treatment, family planning, etc. And then by giving them proper diagnosis and labeling them with the proper condition, some of the patients would be basically getting access to the services they needed. And more importantly, following up, what other things that they need to look at and follow up as part of that syndrome or condition that they have been diagnosed with. In terms of limitation, obviously, negative test result, we always tell our patients, negative test result does not exclude genetic diagnosis, simply because there are testing limitation because of the methodology, or sometimes we are thinking about particular alteration and then it turns out to be a different gene, so we're using the different testing modality, and I'll try to give you some examples. So what are some of the testing that can be ordered in genetics? Very, very simple. Back in the days when the first thing was developed was karyotype, And simply looking at the chromosome under the microscope, just looking for extra whole chromosome or missing chromosome, and the only one that is monosomy that is compatible with life is Turner syndrome. So for your case in endocrinology, if you have someone with short stature, female with delayed period, the first thing you would want to do is do a karyotype to rule out Turner syndrome. So that is applicable to the audience here. From a genetic perspective, another reason we order karyotype is looking for balanced translocation. And what do we mean by balanced translocation? Balance means the individual have all their genetic makeup they need, but it's rearranged in different format. So maybe a piece of one chromosome, for example, 16 attached to chromosome 10 or anything. I'm just using a random example. So the person himself is balanced. He doesn't have any symptoms because he has all the genetic makeup he needs. But what would we notice, or a red flag for us as geneticists? That individual would be, for example, having fertility issues. So a woman might have recurrent abortions or might have difficulty to conceive. Same thing for the father. Why? Because when the gametes are forming, the egg and sperms, they will have abnormal number. So because we're supposed to have half of that copy in each of those gametes, so you would imagine that if there was an abnormal chromosome formed, then when it gets fertilized by the normal, for example, if that was a sperm, if it fertilized a normal egg, then it will result in an unbalanced fetus with abnormalities. Okay, another quick way is FISH, which is fluorescent in situ hybridization. We use FISH for rapid answers. FISH basically can be done in 3 to 5 days in some institutions. 3 days is usually the average. So what they do is they develop specific probes for certain regions or like a specific chromosome. And then they look under the microscope with a light, and then you just see if you have 3 signals from that particular chromosome, then you have a trisomy, or if you have a missing signal, then it's for example, in case of the Turner is monosomy. So so that is usually done for a quick answer. So for example, if we out of context from endocrinology, so for example, a trisomy 21, if we want an answer quickly, it's a Down syndrome patient. We see features consistent with Down syndrome, and we want a quick answer. We can do FISH, but we need to do the karyotype for one reason in case of Down syndrome. Down syndrome can happen because of full trisomy in chromosome 21, or sometimes it can happen because of unbalanced translocation between chromosome 14 and 21. For example, that's the most common Robertsonian translocation, or sometimes because of mosaicism. So obviously, from a genetic standpoint, the counseling for recurrence risk between full trisomy versus Down syndrome because of translocation is totally different. The latter would have a higher recurrence risk chance. Okay, so that's very simple. Now we get to more of some of the hot topics here in genetics. So SNP microarray, if you've heard, or chromosomal microarray. What do we mean by that? So SNP stands for single nucleotide polymorphism, and these are areas of polymorphism across our genome. And we develop basically, it's like probes, and it will just read through, and you will see if there is a copy that is missing. So this is 0 is the log. This is the centromere here. That's why we don't pick up a signal. And then if there is a missing copy, this is what we will see. Or if there is a duplication, this is what we will see. So +1, -1. So we can use SNP microarray to detect microdeletion and microduplication. And I will dwell on the indication for each of those testing in a little bit. And also another way to harness microarray for us from a genetic standpoint, it can tell us about the regions of homozygosity. In our region, consanguineous marriage is very common. So sometimes if we do a microarray on a patient with known family history of consanguinity, we can look at the areas of homozygosity. And we have a database that we can go and log these regions of homozygosity. And then we can see what sort of single genes that lie within those areas of homozygosity. And then if any of those genes are autosomal recessive, OMM phenotype, then we can look if the patient features fit that, and then we can also go and test for that particular gene. We no longer use that because now with the advancement of technology, now we have next generation sequencing. Before next generation sequencing, it used to be the old-fashioned Sanger sequencing. They will literally sequence like nucleotide by nucleotide. And this is how actually they did the Human Genome Project, but they managed to finish it. And after that, the technology has advanced. So we started sequencing the genome in shears or fragments. And then those fragments are then aligned according to with a reference to the reference library. And then we try to pick up the difference. If there is deletion, small deletion, not a micro deletion, small deletion like nucleotides or extra nucleotides, or like missense or frameshift mutation, these kind of things. The beauty of the next generation sequencing is basically you can sequence the entire genome in one run, again, as I said, in fragments, and then that would be aligned against the reference. And then you can start using library, and then you do your analysis, and then you start searching for the diagnosis. And with that, basically you're literally sequencing. When we talk about exome sequencing, the exons, if you remember from biology, these are the coding regions of the genome. Within the gene, the genes are composed of exons and introns. So when we do exome sequencing, we literally sequence the exonic regions only of all those 25,000 genes. But when we do the genome, we also include the intronic region. The intronic region rarely includes deep intronic variants that can alter splicing and how the body reads the message, and then therefore can cause disease. So that's the difference between exome sequencing and genome sequencing. And this picture highlights, depicts very well, the higher the resolution, the more variants we're able to detect. Obviously, the higher the diagnostic yield, but on the expense of more incidental finding, because we're basically sequencing more and we're learning about more of our genetic makeup. Well, if you recall, when I said 25,000 genes, if you would guess how many of those genes we actually know the function of, or we have linked them to disease. Probably, if I am generous, now we are in 2021, maybe 8,000 to 9,000, somewhere between 7,000 to 9,000 genes that we know. So we have a lot about our genetic makeup that we don't know yet. So the advances in genetic medicine is basically, or the goal in genetic medicine is to hopefully by the end we reach a conclusion for each gene. What is the disease linked to it, or what does it exactly do? Because some of those genes not necessarily will have a specific function within the body, but it might affect another gene function, or it might be like a transcriptional factor or something like this. So with that being said, when we talk about exome and genomes, it's not, with how advanced it sounds, it still has its own limitation. It will still not be able to pick up, balanced translocation that the simple karyotype can do. So far, no genetic testing can identify balanced translocation except the karyotype, a high resolution karyotype. When we talk about, aneuploidies, that will not be picked up by exome and genomes. When we talk about, some of the repetitive, like trinucleotide repeats, that will not be picked up by exomes and genomes, because it simply the machine cannot tell if this repeat is there or like what is it exactly. It doesn't understand. Okay, so when we talk about indication for some of those testing, karyotype, I pretty much explained to you when do we do karyotype. So, couples with repeated pregnancy losses or family history of a balanced chromosome rearrangement, or we're looking for aneuploidies or Turner or Klinefelter. If there is low-level mosaicism suspected, that will be done through karyotype. FISH for a quick answer or a specific, if I, for example, have a patient with Williams and we know the region for Williams, we can design FISH probe for that and just to confirm the diagnosis. That's the quickest way. For chromosomal microarray, if you ever have anyone with, unexplained developmental delay or intellectual impairment, someone with autism or autistic features, someone with dysmorphic features, someone with multiple congenital anomalies, or, some of the psychiatric manifestation like schizophrenia or seizure disorder, first-year testing from a genetic standpoint is chromosomal microarray. If the patient phenotype obviously does not fit, a specific recognizable syndrome, because we don't recognize all these 6,000 or 7,000 rare disease that we hear about, then we go for exome and genome. And those include a wide range of neurodevelopmental disorder, a lot of the congenital anomalies that are not explained by microdeletion or microduplication. And again, as I mentioned, dysmorphic feature that does not fit a specific recognizable pattern or phenotype. So these are indication for basically going for exome or genome. So it's not easy. It's, yes, it could sound like as it's one test. However, it has a lot of implication on the patient from the psychosocial or psychological aspect or reproductive repercussions of that testing and its result, the familial, impact of the finding from that genetic testing. And then nowadays, we also have to consider insurance because genetic testing is not covered by insurance, especially for the vast majority of population of patients that we see. So obviously, before doing genetic testing, we have to obtain an informed consent. And from a genetic standpoint, we have to discuss a lot of things. So pre-genetic testing counseling should be done properly. And that should include, proper family pedigree. Why is it important? From a genetic standpoint, that can help us later on when we encounter, some of those incidental findings we talk about. The family history can be something that we can go back to and then test another affected individual within the family. And then they can solve that mystery, perhaps, in some of those cases. And then we have to discuss with the patient, why is this test being recommended? Why it has to be done? If it even has to be done, why now? What can it detect? What cannot it detect? So these are like the limitation of the testing. So if I'm doing a chromosomal microarray, I'm only looking at microdeletion, microduplication. I'm not looking at single genes. So that's a limitation. And I have to explain that to the patient. And I have to explain to them what sort of incidental finding can be identified from those genetic testing. And then what will be the follow-up plan after that? So I always include these 4 major things in my counseling for the patient. And I tell them any genetic test we do, whether it's a karyotype or whole genome sequencing, we can either have a positive or abnormal result, meaning I go there and find the causative genetic change that explains my patient phenotype, or a negative result. Basically, I don't identify what is causing the phenotype of my patient. However, remember that a negative genetic testing does not rule out the possibility for a genetic etiology because of the test limitation or because of the limitation of our knowledge. As I mentioned, we don't know all the 25,000 genes in the human genome. And then most importantly, we have to let them know that there is a chance of finding variant of unknown clinical significance. You've heard this word from Dr. Araya's presentation, and I would like to explain it a little bit further. So what do we mean by variant of uncertain significance? So I'm going to step back and say genes are letters, basically, right? So when we identify a letter change, that's basically a mutation. The lab basically classifies those mutations, and we have 5 classifications. It will be classified either as pathogenic or likely pathogenic, benign or likely benign, and then the last one is variant of unknown clinical significance. So the variant of unknown clinical significance is classified that way because we don't have enough evidence either from patient population or from patients' previous studies or from lab studies to prove if this is really truly pathogenic and it alters the gene function and therefore can result in a disease, or is this variant benign and it doesn't change the gene function and the body is still able to read that message and do the gene function as it's supposed to do. So it remains in that classification until more evidence is gathered, okay? And then I also have to warn them, especially when we do microarray or when we do genome or exome, incidental finding, meaning I find something else, not relevant to my patient phenotype, but it can tell about future risk of, like, for example, cancer predisposition or cardiomyopathies, etc. And there are like 70 plus conditions that are mandated by the American College of Medical Genetics to be reported when we find them in the exome of a patient or like microarray of a patient to basically inform the patient about those results. BRCA gene, for example, or Lynch gene or something like that to predispose them to breast cancer or colon cancer. Okay. So with that, I would stop my presentation here, but I would like to share with you, if you have patients, where can you refer them? So in Tawam Hospital, Tawam and CMHS, we have general genetics clinic that are run by Dr. Aisha Shamsi and myself. and metabolic clinic by Dr. Joseph Hertik and Dr. Aisha Shamsi, myself, and Dr. Fatma Jasmi. And we do have a cancer genetics clinic that's also relevant to the endocrine and society. There are cases that can be referred to the clinic. It's run by myself. And then the premarital clinic for now is only for the known families with certain conditions that we are aware of. So they get carrier screening basically. But now in the near future, this probably will be expanded. In different parts of the Emirate, you have Dr. Fatma Al-Bastaki and her team in Latifa Hospital in Dubai, and Dr. Nuha Zaabi just recently graduated and is in Fujairah Hospital, also providing services there. I would stop at this in the interest of time, and I will take it back to Dr. Badur. Thank you very much for listening.
Thank you very much, Dr. Anora, for this nice overview. And it's nice to know that we are having a subspecialized clinics in UAE, and so we know where we can direct our patients. So now we're coming toward the Q&A session. So I would like to invite the panelists to this session and to address the audience questions. So we have 15 minutes for this session, so I'll try to go as much as I can through most of the questions that is posted by the audience. Thanks all for your presentations, and I'm very delighted that we have almost close to 500 attendees for our tonight's activities with a very interactive discussion. So we start with the first question directed to Dr. Asma. If you can give us a brief answer, Asma. The first question is how to manage diabetes inpatient for patient admitted and planning to go for OR next day. Probably you have went through this, but for reinforcement, if you can give a brief answer for this question.
I addressed this clearly in my presentation and brief that it depends on the patient. If the patient is going for emergency surgery or elective surgery, I think the patient, the attendee asking about the elective surgery. So if the patient is going for elective surgery, the night before, the patient will take his medication. If the patient is having very well controlled the blood glucose and on basal insulin, I would cut down the dose of the basal insulin by 20%, less than his usual dose. Or if the patient is MPHF the night before, would be cut down 20% before. The day of surgery, it depends on the timing of the surgery. Is it early in the morning, or it's going to be delayed during the noon or afternoon time? Oral medication, all of them is going to be stopped. The patients will be monitored since morning by point of care. The target would be 6 to 10 millimole. As I said, that's around 110 for patients with well controlled, 110 to 180 or 140 to 180. The insulin would be given if the patient is off target, more than 10 millimole. Insulin will be given based on the sliding scale. This is a brief. Then after the surgery, the patients will be, if the patient is going to be kept MPO, patient will be on sliding scale and can take basal insulin or MPH 20 to 25% less than his usual dose. No fixed dose of insulin should be given, and no oral medication should be given till the patient go back to his normal state of eating.
Okay, we'll continue with you, Dr. Asma, for a couple of questions. Next question, if patient is on TPN or patient on enteral feeding, both posted by Dr. Amira Zahrani, can we use the MDI regimen, the Lantus and the correction and the fixed dose, instead of like adding the insulin regular doses in the TPN bag?
So,
can we use the MDI regimen?
When you think about TPN, you're talking about very sick patients. That's why they're on TPN. TPN contains very high carbs, amount of carbs. The minimum is 200 grams of dextrose. So it is advisable to give it to the TPN bag as regular insulin. And sliding scale actually should be still implemented, because if the TPN is run over 24 hours, you cannot adjust the insulin doses in the back of the TPN. So patient should still receive sliding scale throughout the day. Then when the pharmacy start to prepare the next day insulin through the TPN, they're going to adjust the dose of the regular insulin based on the last 24 hours requirement from the sliding scale. So for the TPN, it's advisable and recommended actually from many societies that the patient should be on insulin, regular insulin through the TPN bag plus sliding scale sub-Q. Regarding the enteral feeding, there is no incorrect answer. So with patient can be, I think she asked about the continuous feeding. If the patient in continuous feeding can still be on basal insulin with multiple boluses, the best would be starting the patient on MPH 3 times with the boluses for correction, because the MPH would have a bit better control for if the patient is having higher blood glucose after the, initiation of the TPN. Oh, sorry, enteral feeding.
So you're favoring MPH over the MDI regimen for the continuous enteral feeding.
So I answered this question.
Then next question, the HbA1c is unreliable end-stage renal disease. How you can put a plan to avoid hypoglycemia in such population?
This is correct. In general, we still treat end-stage renal disease like monitoring their glycemic control with the hemoglobin A1C, like the patients with diabetes who doesn't have end-stage renal disease. I understand that if the patient is having end-stage renal disease, there is overestimation of their hemoglobin A1C for many reasons, because they're having very short lifespan of RBCs, frequent maybe blood transfusion, patients having iron deficiency and anemia, patient is also an erythropoietin. So all these would affect their hemoglobin A1C, especially those patients would have also high urea, which affect the hemoglobin itself. So studies show that if the patient is having hemoglobin A1C between 6 to 7, that would be similar to patients who has no end-stage renal disease. So I would not worry about the differences here. But if the patient is having more than 7.5 hemoglobin A1C, that might be overestimated. So in reality, the patients might have lower than that. So I would monitor if the patient is having hemoglobin A1C more than 7.5, and the patient is on treatment, I will monitor them. If they started to have hypoglycemia, that means that there is an overestimation. I can use in this time, or which is going to be give me a better prediction of their control. I can use fructosamine as a better indication of their blood glucose control. But you should bear in mind that if the patient is having proteinuria or high albuminuria, fructosamine also is going to be affected.
The other question about outpatient management for hyperglycemia. Someone tested positive for COVID-19 and he's planned to be discharged on steroid agents. So how would you treat this patient at home? What instructions would you be giving him?
So the patient is hospitalized and is going to be discharged home.
No, he's positive, but he'll be managed as outpatient.
Okay, so this is the completely different topic. We're discussing inpatient hyperglycemia. So for outpatient hyperglycemia, if the patient is ambulatory, in ambulatory setting, we're expecting that they're not having a severe COVID status. So they're having a mild COVID status. So for such patient, I would continue the same treatment for them. But a clear instruction should be given to the patient if they're having good oral intake or not, because many medications should be adjusted. For example, if the patient is having poor oral intake, very fatigued, he cannot have his usual oral intake and he's on sulfonylurea, I would ask them to stop the sulfonylurea. If the patient on SGL2 inhibitors, also it's advised to stop it for many reasons. Both of them cause SGL2 would cause volume retraction, predispose them to have DKA, especially in the case of infection and sepsis. It might have severe UTI. Metformin also might be risky in such patients. DPP-4 is going to be the only medication can be continued. If the patient is insulin, I would also adjust their doses. I will ask the patients to monitor their blood sugar. If it is more than 200, they might go back to their sulfonylurea to take it. Or if the patient is having also insulin, they might increase their basal insulin. I would advise them to stop short acting if they're having poor oral intake, but at the same time, I will ask them to use the sliding scale. If the patient is type 1, I would advise them to check their point of care ketones. I mean, to avoid going into DKAs in such condition.
Thank you, Dr. Asma. I'll move to Dr. Raya. The question that is posed to you, Raya, is how would you approach a pregnant lady who have the glucokinase mutation?
Okay, this is a very good question. So now, during a pregnancy, you are concerned about fetal growth. And fetal growth depends on the fetal genotype. So if the fetus have the mutation of GCK like his mother, then both of them have the same glucose set point, and you will not be worried about excessive fetal growth. However, what we will be worried about if the mother is GCK and she have hyperglycemia, but the fetus is not affected. That's mean GCK negative. In this case, the fetus will be exposed to too much glucose and there will be excessive growth. Now, the question is how I will know the genotype of the fetus? And maybe with the current what they call it, cell-free DNA, it can be used in the future to know the genotype of the fetus from the maternal blood. However, currently what they do is serial ultrasound. And if the serial ultrasound document excessive fetal growth through the measurement of the abdominal circumference, then this is indicative of macrosomia. And this means that the fetus does not harbor the mutation and it should be treated aggressively. And maybe also there will be early induction at 38 weeks. If there is no excessive growth of the fetus, this means that the fetus likely is affected and have GCK, and then you will you don't need to treat at this point, as the patient or the fetus will have the same set point as his mother.
Thanks. There is another question, Raya. You have mentioned that there are studies that they are using the GLP agonist and the HNFA mutation. The question is, how does this work with someone who have insulin defect?
Excellent. So if you remember when I showed the figure, how the glucose stimulate insulin secretion, this is what we call it a triggering pathway. And this is where amino acids and glucose will trigger the insulin secretion through the transcriptional factors and so on, and ATP production. However, there is another pathway called amplifications pathway, where there is increased insulin secretion, again through increased intracellular or cytosolic intracellular calcium. And this is through, for example, mitochondrial derivatives or through GLP-1 agonist. So you could say that through the GLP agonist receptors, you could bypass this pathway through another pathway and stimulate insulin secretion.
Okay. One more question before I move to Dr. Noura. Dr. Raya, how can you differentiate between the honeymoon period of diabetes for type 1 and moody?
I don't know if, well, there's something that I need to emphasize here. When we say we like to have early diagnosis of moody undifferentiated from type 1, it doesn't mean it has to be during this period. Now, for example, in honeymoon or early onset type 1 diabetes, you will have already detected C-peptides. So you will not use this method. However, autoantibodies most likely to be positive at the time of the diagnosis. And therefore, antibodies at the time of diagnosis are, the yield of these antibodies are the highest. And therefore, if the antibodies autoimmune are present, then this is likely type 1. If not present, then you may follow the patient. And with the follow of the patient, some clues can come to you, especially that patient with type 1 will not remain in honeymoon after 3-5 years of diagnosis. I think
Thanks,
this is the way.
I'll be moving to Noura now, Dr. Noura. For patients that you have mentioned, the category of patient that is variant of unclinical significance, the gene test that presents with variants of unknown clinical significance, how would you approach that, Noura?
So again, if we have obtained a careful family history, if there is a variant of unknown clinical significance, let's say in one of the genes for Moody, if there is another affected family members, we can test that family member and then see if that is a common variant between the two, siblings, or a son and a father, or a daughter and a father, or something like this. That might give me a clue that another affected individual has the same variant in that gene, and they both fits the phenotype, then that's another evidence for me. But unfortunately, that's not enough for the lab to reclassify the variant from VUS to likely pathogenic or pathogenic. For it to be classified as pathogenic or likely pathogenic, especially pathogenic, they need really stringent criteria. De novo variants, so if it was in the individual himself and not from a father or mother, that gives it more likely chance for it to be more pathogenic. But still, you need either an in vitro study to prove that, or previously published patient population, or another patient case series or case report about another patient with that same variant. So the way I'd approach it, usually I'll try to find another affected family member and try to solve it that way. Like segregation analysis, that's another term we use in genetics.
Second question for you also, Dr. Noura. When do you decide to go for gene panel testing versus exome sequencing?
Before I answer that, just going back to the VUS, also making sure that actually that gene fits my patient phenotype. So if it's a VUS and a gene that doesn't even, if I do an exome, for example, and that VUS is in something not relevant to my patient phenotype, I might not prioritize it as something that I would look for and carefully search for it. I would try to prioritize variants within genes that fits my patient phenotype. So going back to the second question about when do we do panel versus exome. So panels only include certain set of genes. Like for example, we have Moody panel that includes only the so far known genes for Moody. We can test for that. But within a panel, the coverage, or especially the first exon of that particular genes included in the panel, might not be very well covered. So we can do it as a good start. And most of the labs have improved their methodology to cover them very well to the best of their ability. However, that remains one of the test limitation. We go to exome if the patient phenotype is beyond only that particular condition we're thinking about. Not only exome, even for example, considering array. But let's talk about exome first. So let's say, for example, it's I suspect Moody, but the patient have extra systemic manifestation. So maybe dysmorphic features and maybe some other system involved. So I suspect basically another syndrome, not only Moody. So I can consider an exome, but I should not, if the exome is negative, I should also consider a chromosome 1 microarray. Because as Dr. Raya mentioned, it's very rare that there are microdeletion in some area of the genome that includes genes for Moody, for example. Those are rare. So the patient phenotype will be explained by the microdeletion because there are other genes within that region that can explain the patient phenotype, and then the deletion of that particular Moody gene explains the patient diabetes. So I think it's driven by patient phenotype mainly.
Thank you so much, Dr. Noura, and my apologies for the rest of the questions. The time is really very limited, and we have to move to our fourth speaker. So we'll move to Dr. Ghaida. So Dr. Ghaida will give us a talk about glycoside safety and effectiveness in real-world settings, evidence during Ramadan and beyond. Dr. Ghaida Qadaha, she's a senior endocrine consultant and diabetologist at Dr. Suleiman Al Habib Medical Center in Dubai, UAE. She's also associate professor of medicine at Dubai Medical College for Girls, participated in more than 14 researches in the field of diabetes and hypertension. She has several publications related to diabetes and Ramadan. Dr. Ghaida, the floor is yours. Kindly unmute your mic and share your presentation.
Thank you very much, Budur. Okay, thank you, Budur, for the introduction, and good evening, dear colleagues. I'm really delighted to be on this Young Leaders Forum to share with you the results of a real-world study of the safety and effectiveness of glycoside MR during Ramadan fasting. On the occasion, happy Ramadan to all of you. This is my disclosures. And in this era of evidence-based medicine, we know that the best evidence really comes from clinical research, yet expert opinion and patient's perspective are important contributors to the decision-making process when delivering any healthcare service. More recently, we're aware of the added value of real-world data that's collected outside the rigid constraints of clinical trials, data that represent really what's happening in the real world. So while clinical trials are really trying to answer the question if any particular treatment or intervention works, real-world data tell us whether when this treatment is applied in the real world, does it really work? And today I'll be sharing with you the results of such a real-world study, which addresses the safety of 1-sulfonylurea during Ramadan fasting, and try to answer the question if the safety of sulfonylureas is compromised during fasting. The study is the DIA Ramadan study. It's an international real-world study assessing the safety and effectiveness of glycoside MR during Ramadan fasting. But before I discuss the DIA Ramadan study, I would like to share with you the results of 2 clinical trials that looked at the safety of glycoside in comparison with other sulfonylureas. And the first study is the GUIDE study. This is a multi-center, double-blind, randomized study comparing 2 third-generation sulfonylureas in terms of their efficacy and safety. And this is glycoside MR and glimepiride. And the study was carried out for 6 months. And as you can see at the end of the study, both sulfonylureas, both glycoside and glimepiride, are very effective in glucose lowering, producing a 1.2 to 1.3% reduction in HbA1c. What was really very different is the risk of confirmed hypoglycemia. Patient with glycoside, I'll try to get the laser. Patients on glycoside had less than half as many confirmed hypoglycemic episodes compared to glimepiride. And when the study population was divided into those who are less than 65 years of age and those who are more than 65 years of age, you can see that the same results were shown. Glycoside-treated patients had much less hypoglycemic episodes compared to glimepiride. Another study that was conducted in Ramadan of 2009, and Rashid Hospital at the time was one of the participating centers. This study looked at the incidence of symptomatic hypoglycemia in sulfonylurea-treated patients during Ramadan fasting. And what came out from this study is that around 20% of sulfonylurea-treated patients will develop symptomatic hypoglycemia during fasting. But when the study population was divided by the kind of sulfonylurea the patients are taking, it became apparent that the highest risk of hypoglycemia was happening with patients on glibenclamide, Glipizide also, but the number of patients in the glipizide arm were really very, very small, so it's very difficult to say what was happening here. But what was very apparent is that the glycoside-treated patients in this study had the lowest risk of hypoglycemia, even lower than glimepiride-treated patients, another third-generation sulfonylurea. And when in the same study, they looked at severe hypoglycemia requiring assistance, again, glycoside-treated patients had the lowest risk ever among all the sulfonylureas of developing severe hypoglycemia. On this background, I would like to discuss with you the results of the DIA Ramadan study. And as I said earlier, this is a real-world observational study of the safety and efficacy of glycoside modified release. And the background is that we know the sulfonylureas are very effective drugs in terms of their glucose lowering potency, but this comes at the expense of increased risk of hypoglycemia and weight gain. But as we have seen from the previous two studies, it seems that all sulfonylureas are not the same when it comes to the risk of hypoglycemia. And glycoside is, as you have seen, is well recognized to be associated with lower risk of hypoglycemia, even when compared with other newer third-generation sulfonylureas. And this is probably attributable to the fact due to the modified release preparation that caused very slow release of the active substance from the tablet. So the objective of the study was to assess the safety and efficacy of glycoside modified release in patients who are well controlled or suboptimally controlled. So everyone had to have an A1C of less than 9%, and they had to be treated with the glycoside, and they had to be fasting during Ramadan. The primary endpoint of the study was the proportion of patients who would develop at least one episode of symptomatic hypoglycemia, whether confirmed or not confirmed by a capillary blood glucose less than 3.9 millimoles or 70 milligrams %. They looked at other secondary endpoints. That's the change in HbA1c from baseline, the change in fasting blood glucose, and the change in weight between the two visits, as we will discuss in a minute. They also looked at the proportion of patients with at least one confirmed hypoglycemia and the proportion of patients with any hypoglycemia, whether confirmed or not confirmed, symptomatic or not symptomatic. So the study was carried out in 64 centers across 9 countries. 1,214 patients participated in the study. And the main inclusion criteria was you have to be type 2 diabetic, adult more than 18 years of age. You have to be well controlled or suboptimally controlled. So you have to have an A1C of less than 9%. You have to be treated with the glycoside for at least 90 days prior to being included in the study. And you have to know how to monitor your capillary blood glucose at home, and you have to be willing to fast during Ramadan. Excluded are patients who are insulin treated, those who are poorly controlled with an A1C of more than 9%, those who have severe liver or renal disease, and those who have unexplained recurrent severe hypoglycemic episodes. If you fulfilled all these inclusion and exclusion criteria, the patients were recruited at visit 0, where the demographic, clinical, and lab data was collected, and the patients were given a diary on which they would record any hypoglycemic episodes occurring during fasting. The first visit, which is visit 0, happened 6 to 8 weeks before Ramadan, and then the patients were followed throughout Ramadan, and then the second visit 4 to 6 weeks after Ramadan, whereby the diaries were taken from the patients, and they looked at hypoglycemic episodes. And you can see this is the typical patient population of type 2 diabetes, average age of 54, a very good representation of women in the study, 45%, mean disease duration of 5.4 years, obese as you'd expect, 28.4 the BMI. Some of them had arterial hypertension, of course, some of them were dyslipidemic. Everyone had to be on glycoside, either in monotherapy or in combination with other oral antidiabetics. Let's look at the results of the study. And during Ramadan, 1.6% of the patients developed confirmed hypoglycemia, and the primary endpoint of the study was symptomatic hypoglycemia happened in only 2.2% of the studied population. If you remember, in the observation study that we participated in 2009, 20% of sulfonylurea treated patients had hypoglycemia. So really very low risk. So this is the primary endpoint, 2.2% hypoglycemic episodes. And as I said, they looked also at the A1C, and there was a 0.3% reduction in A1C, and there was a half kilo weight loss. So this low risk of hypoglycemia did not really happen at the expense of deterioration in glycemia or an increase in weight. And the study for the first time shows that in real world setting, that people with type 2 diabetes treated with the glycoside can safely fast during Ramadan with very low risk of hypoglycemia. The study population was divided into the various regions. And as you can see, there were 564 patients from the Indian subcontinent. There were 354 patients from the Middle East. These are the participating countries: Egypt, Kuwait, Saudi Arabia, and the Emirates. And there were 296 patients from Southeast Asia. And I'll quickly go through the baseline characteristics. I'm not going to go into the details of this, just to highlight the point that patients from the Middle East, on the average, had higher HbA1c, higher fasting blood glucose, and higher mean glycoside dose. Also, the patients from the Middle East had higher established cardiovascular disease. And what I find very surprising in the study, that a very good proportion of the patients, almost 47%, they were just on glycoside monotherapy. And we know that we use sulfonylurea either as second line or third line, never as first line, but unless the patients, are intolerant of metformin or metformin is contraindicated. But as you can see, there's a good proportion of the patients are only on glycoside monotherapy. This is just to say the same thing. Glycoside monotherapy was highest among in the Middle East region compared to the other two regions. Again, very low rate of symptomatic hypoglycemia among all the three regions. Not a single episode of severe hypoglycemia throughout the study in any of the regions. And as I mentioned earlier, this did not happen at the expense of any deterioration in glycemic control. If anything, there was a significant but very modest reduction in HbA1c, and the greatest A1c reduction really was in the Indian subcontinent, almost 0.4% reduction in HbA1c between the first visit and the second visit, and a very small reduction in HbA1c in all the other regions. And also a reduction in fasting blood glucose happened, during, again, this is seen most prominent in the Indian subcontinent. The weight, there was a slight reduction in weight, significant but very modest. We're talking on the average about 0.5 kilogram reduction in weight. So the point to mention is that there was no deterioration really in glycemic control and no weight increase despite the very low risk of hypoglycemia. So just to summarize, it's safe to say that most people with type 2 diabetes can fast during Ramadan safely if the healthcare provider gives them the right advice and prepare them to the month of fasting. Choosing the right sulfonylurea at the right dose at the right time can, guide them safely during the fasting month of Ramadan. I hope I was able to share with you the results of this clinical trial, which is a real-world study showing that patients taking this particular sulfonylurea glycoside MR is associated with very low risk of hypoglycemia, and we have not seen a single episode of severe hypoglycemia in this study. And with this, I conclude my talk, and thank you very much for your attention. And it was very late in the night, and you people are very tired, but I'm really ready to answer any question that you may have.
Thank you very much, Dr. Thank you very much, Dr. Ghaida, for this overview and the real-world evidence trial. There are a couple of questions. I know we are uh, late in the evening, but I'll address some of them. The question for you. Uh, so from this trial, do you say that this is the safest SU, the gliclazide is the safest SU during Ramadan, if you would choose?
Yes, I mean, honestly, if I have to have my patient on a sulfonylurea during Ramadan, yes. There's, as I've mentioned, there are several studies to show that in terms of the risk of hypoglycemia, this is really the safest. It's true.
Okay. The second question is outside the context of Ramadan, but the question is gliclazide safe during pregnancy?
Um, I wouldn't use it during pregnancy, though there was some studies on the use of glibenclamide in pregnancy. In some, I can't remember exactly where the study was conducted, but there was a study on glibenclamide in pregnancy. But honestly, these days, I mean, the only oral antidiabetic I would use during pregnancy is metformin. And if metformin doesn't work, I usually move to insulin. I'm not going to use any sulfonylurea. I have not really used gliclazide or any other sulfonylurea during pregnancy.
It's safer to avoid them.
Yes.
Okay, a question away from gliclazide. It's about SGLT during Ramadan. Is there certain population that you would stop the use of SGLT use during Ramadan?
Honestly, if the patient is well controlled and tolerating the SGLT2 inhibitor prior to Ramadan, I would continue. With the advice, I usually advise them to hydrate properly during the non-fasting period. So after iftar, I tell them, encourage them to drink plenty of water. If the patient is tolerating it, I don't stop it. I'm careful during fasting, like I'm careful outside the setting of fasting, in patients who are on diuretics, for example, patients who experience postural hypotension, the elderly. I would be very concerned about the risk of dehydration and postural hypotension. Of course, also the risk of mycotic genital infection and urinary tract infection is also well known. But in terms of Ramadan, I may not initiate the SGLT2 prior to Ramadan. That's not the time to start anyone on SGLT2 inhibitor. But if they are on it, I would continue.
Okay, so cautious use and
Yeah.
no starting before, no new start before Ramadan.
Yes.
Question regarding the trial. What was the highest tolerated dose of gliclazide used in this multi-center study?
The patients, the dose was modified during Ramadan, but I don't have exactly, I mean, they used all the doses from 30 milligram all the way to 120 milligram.
Okay. Dr. Ghaida,
But of course, the dose would be modified, during Ramadan.
Okay. Dr. Ghaida, another question. Is there a difference in the anti-hyperglycemic effect of the gliclazide between 60 mg and 120 mg?
Is there a difference?
In the anti-hyperglycemic,
Yeah.
whether we use standard or super standard dose?
You mean, I mean, the higher dose, of course, is
Yes.
more potent.
Yes.
Of course, I mean, you'd expect a greater A1C reduction and a greater blood glucose lowering effect with the higher dose. Is that what is meant by the question?
The question is comparison between the 60 and 120, if there is major anti-hyperglycemic difference.
Yes, definitely. Yes, there is.
Okay.
In terms of the glucose lowering efficacy, the higher dose is more effective, definitely.
More effective. Thank you so much, Dr. Ghaida. We are really
You're welcome.
time. I know there are many questions, but I think we exceeded our...
I'm amazed at the audience who are still, so active and asking questions. Amazing. Thank you so much, Budur. Thank you to all the panel and the audience.
Thank you so much. We're so delighted tonight with our distinguished speakers and audience. So kindly, I would encourage the presenters to log in into the EDS website to address the rest of the questions that we could not answer during our discussion. That was a very nice talk today, and I have enjoyed all the presentation, including the discussion. So by this we end our forum. And again, just to remind you that the CME will be available in 10 days after filling out the questionnaire. And the webinar is available on demand on the ADES Institute website as well on the EDES YouTube channel. Thanks again for the presenters, audience, and thanks for our sponsor, Servier. Our upcoming EDES activities will be webinar on dyslipidemia. We'll be having an EDS Connect session on diabetes and endocrine, and the Young Leader Forum, the second edition. Later, the dates will be announced. Good evening, all, and have a great evening. Assalamu.